among the member states. So the first recommendation was on annual reporting, whereby the member state were required to report the progress of implementations of IHR in their country yearly through the World Health Assembly. So it provides a snapshot of this. Okay. And then WHO also recommended on the simulations exercise regularly, either being conducted or participated by the member states. So this is to test the core capacity functionality, as well as WHO also were advised on the after actions review, which is characterized the core capacity functionality of the country. And WHO also promoting the countries to involve and participate in joint external evaluations, or JE, whereby it is a voluntary evaluation process done by countries. So the objective of this JE is to measure the achievement of the core capacity based on the evaluations by the external reviewer. So as a guiding principles of IHR monitoring and evaluation framework, this is the documents of IHR MNE. So basically, it's promoting on transparency of the member state in developing or in providing or improving their capacity and capability in responding to any public health emergency, and it is based by the mutual accountability, trust building, appreciations of public health benefit, dialogue, and sustainability. So Malaysia was one of the country whereby at the regional level in WHO, we were included into Western Pacific regions of WHO office, so which we call it WEPRO. So WEPRO had made an initiative to come out with this ASEAN Pacific strategy for emerging disease and public health emergency, which it will at the focus area of this document, or what we call it upset, is to advancing the implementations of international Health Regulation 2005, which it's provide a guideline for the member states under WIPRO region to build up their capacity and capability for public in preventing, detecting, and response to public health emergency. So this is the visions of upset. So an Asian Pacific region able to prevent, detect, and respond to public health emergency through collective responsibility for public health security. So inside the upset itself, it's covering 9 core main area, which it involve the strategic for public health emergency preparedness, surveillance, risk assessment and response, laboratory, monitoring and evaluations, zoonosis, preventions through healthcare and risk communication, as well as the complements the whole strategic into regional preparedness, alert and response. So by having these 9 strategies, and in which its strategies had activity inside it, it will be a tool of guides of the country member states under WIPRO to improve their capacity building. So this is what have done at regional level. So we actually now focusing more on Malaysian preparedness on a public health emergency, and particularly in this context on the COVID-19 pandemics. So Malaysia basically in responding to pandemic, so preparedness is one of the crucial important and the juice from the IHR 2005. So whereby when BEPRO had already come out with upset, so Malaysia had taken an initiative to come out with our strategic plan as well, which we call it MySet 2, which I explain later. And we also, in order to monitor the whole MySet activity, we take out the recommendation by WHO by regularly participating and conducting simulations exercise, annual reporting. We also in voluntary join the joint external evaluations conducted by WHO, and also in any public health events or any occur in Malaysia, we also conducted after actions review. So what does this mindset 2 means is, it is a Malaysian strategy of emerging disease and public health emergency work plan. So basically it's covered 8 focus areas involving public health emergency preparedness, surveillance, risk assessment and response, laboratory zoonosis, prevention through healthcare, risk communication, regional preparedness, alert and response, monitoring and evaluation. So basically all these focus areas were a mirror image as well on what upset had been translated. So in this context, my set were tailored more on Malaysian setting. And the beauty about this mindset is not only the preparedness activities that include the preparedness and response among the health agencies in Malaysia, but as well as include multiple other agencies such as Department of Veterinary, National Security Council, National Disaster Agencies, whereby we know all these agencies, they were also actively in participating in response as well as in preparations towards any public health emergency in Malaysia. So basically, this document come up with all the agencies come together as one government in preparing the countries for public health emergency events. So Malaysia also actively conducted simulation exercise at national, at the state level, whereby this simulation exercise, basically it will be tested on the core capacity developments that we have done at all levels. So in Malaysia, we have at the district level, at the state level, and the national level. So this combination exercise were done regularly to ensure that the capacity buildings is at optimum level, to identify what will be the weakness, what will be the strength, and regularly evaluate our strategic plan. And as well, Malaysia also participate in regional and global simulation exercise as well. So this is some of the activity at the national level. So basically, we conducted several simulations exercise, and we also involve relevant agencies such as Department of Veterinary, National Security Council, National Disaster Agencies, whereby it's not only to test the capacity of health agency in Malaysia, but as one government. And on top of that, we also conducted simulation exercise interborder, such as this is some of the examples that we had joint avian influenza simulation exercise with our border with Thailand. So and we also involved in conducting regional simulation exercise as well. And Malaysia was fortunate that time on 2018, we had been selected to participate in Global Emergency Operations Center exercise, simulation exercise, whereby in WEPRO region, Malaysia the only country selected to be participate in this simulation exercise. So this is the 3D tabletop exercise conducted by WHO Geneva, which is not only testing the capacity of emergency operation center, but the overall preparedness and response of public health events during that time. So one of the big challenges was this simulation exercise was conducted in Geneva, so there are a lot of time difference, and it was a very good exercise in order for us to evaluate our capacity building in Malaysia. And again, Malaysia is actively participate into this crystal simulations exercise, whereby WEPRO had made this initiative to conduct crystal exercise, and it was being conducted for such a long time, and way before we had pandemic influenza 2009. So this regular simulation exercise, which we call it crystal exercise, was conducted yearly, mainly during December, and the objective of this crystal exercise is to what we call it, to evaluate the functionality of international health regulation focal point of the member state in WIPRO region. So basically in this simulation exercise as well, we involve all level of administrative. We have from people from state, from district, from the national, from the other departments such as Department of Veterinary, Department of National Disaster Agencies. So it involved with other agencies as well. And also this is our team from lab. And again, into 2020, when we have a middle of pandemic, Malaysia also did join this crystal exercise in the middle of pandemic, where this picture shows that we conducted crystal exercise in December 2020, and it was very timely because the scenario that time it was given to test out our capacity on the implementations and distributions of vaccine of COVID of vaccine. So basically, it was timely just before we started our national immunization program for COVID-19. So even though pandemic occur, it doesn't stop us to continually evaluate our strategic plan. And of course, one of the requirement under IHR is to yearly reported in World Health Assembly on the progress of capacity building of the member state in World Health Assembly. So basically, before that, in WIPRO region, we also had the regional committee meeting whereby the country or the member states also required to report the progress of implementation of IHR at the regional level. And way before that, WIPRO also had a meeting which we call it upset technical advisory group meeting, whereby the country will share their best experience and lesson learned based on the implementation upsets of at their countries. And it's just timely that Malaysia joined and participate these joint external evaluations. This JE had been conducted on 21st October 2019. So just about 3 months before pandemic occurred. So this report of Malaysia JE had been published in WHO website. So basically in JE, they were invited external reviewer from WHO and from other countries come to the country, and then they will be evaluated based on 9 technical area, and at the end of the report or at the end of the evaluations, they will come up with the summary of what will be done by country to improve their capacity building. And based on our JEE report in 2019, Malaysia had shown a capacity and capability of to detect and respond for public health emergencies. So this is some of the example, the technical area that they are looking at, such as national legislations, policy and financing, IHR coordination, communication and advocacy, laboratories, zoonosis, food safety. There are many more. So it was in intense evaluations done by WHO, which is very good for the country to identify what will be their strengths, the weakness, to improve in the future. And this JE conducted was timely, whereby the weaknesses or the room of improvement can be done during pandemic itself. And then when pandemic occur, this is the time that we shows how good is our preparedness towards a public health emergency, and in this context is pandemic. So this is the situations of pandemic COVID-19 in Malaysia, whereby this is the overall picture of distributions of COVID-19 cases in Malaysia. We have 3 waves: first wave, second wave, and third wave. So our first wave mainly were contributed by the imported cases from Wuhan, China, whereby the first case was reported on 25th January 2020. Basically, we have 22 cases reported in the first wave, and then we have break about 11 days without no case reported. And then this is our second wave, which mainly contributed by our Seri Petaling cluster. And then we managed to contain our second wave, and then currently we are facing the third wave, and we hope that the graph is coming down and flattening. And of course, the increasing number of cases at the third wave contribute to some other factors like the state elections in Sabah, and the relaxations of movement control orders, and as well as there also the global epidemiological dynamic of COVID-19 itself, whereby other countries as well reported increasing number of COVID-19 cases, and the emergence of new variants of COVID-19, so which is also reflects in our third wave of COVID-19 in Malaysia. And this is the recent incidence of COVID-19 in Malaysia. So at the peak here, we can see basically we had 4,000 plus cases a day reported a day. Now currently we've been reported less than 1,500 cases per day, and we hope that the trend is reducing trend. Then how Malaysia approach on this pandemic, we can simplify it into 6 main strategy, which I think we cannot run away from the surveillance and public health intervention. So the strengthening of surveillance and public health interventions was the key, whereby we extensively conducted containment strategies into this. And then we also enhanced and expanded our diagnostic and testing capacity, and with utilizations of RT-PCR as well as the rapid test kits antigens. We had implemented of movement control order. Of course, all the decision had to be driven by the evidence-based approach, and as well as the technical advice from the WHO. And then we believe that good risk communication is the key for the country to be transparent, and to the message could be transferred to the public, and of course isolations and treatments of the positive cases. So one of the requirement under IHR Focal Point is under Article 5, whereby the country or the member state required to assign an appointed IHR Focal Point. And this IHR Focal Point will not only be functioning during pandemic. So Malaysia IHR Focal Point, it was function previously. Basically we are supporting more on Article 44 for assistance and collaboration, whereby if we have any foreign citizen who had infectious disease in our country and they going back to their country origin, we mainly in tuberculosis, we will inform the country of origins IHR Focal Points to inform and to ensure that they apply the appropriate control measures to prevent the outbreak at the area. So the IHR Focal Point for Malaysia itself, it been tested regularly through crystal simulations exercise conducted by WebPro yearly. And during joint external evaluations, the role of Malaysian IHR Focal Point being evaluated at Focus Area 2, whereby it's covered on IHR Focal Point communications and collaborations. So all this, and Malaysia had been shown during our JE at Focus Area 2, IHR Focal Point collaborations, communications and collaborations, we achieved the highest mark, which is 5 score at that time. So and the role of Malaysia IHR Focal Point is truly being tested during this pandemic. And this is some of the example whereby when we first detected our first case, it was a good communications and timely communications with our neighbors, whereby on 23rd January 2020, we received a notifications from Singapore IHR Focal Point, whereby they had identified a close contact of their first confirmed COVID-19 case had entered Malaysia. So by having this timely notification on 24th January 2020, we managed to identify and locate this close contact. We managed to isolate them, and during that time it was not having a proper guidelines on how to handle this asymptomatic close contact. So 8 of them are asymptomatic, and we took an initiative to test them, and it turns out initially 3 out of 8 close contact were positive, and later on there are another one close contact had positive. So by having these timely communications with Singapore IHR Focal Point, we'll be able to contain this COVID-19 during our first wave. So it's only confined to those who are close contact and did not spread in the community. This is one of the good example on how effective and timely communications between IHR Focal Point. And it's also being highlighted during our second wave, whereby we had one of the largest cluster outbreak, which is the Seri Petaling outbreak. So that time, during early March, so Malaysian IHR Focal Point, we received notifications from Brunei IHR Focal Point. That time, they informed us that one of their citizens coming back from Kuala Lumpur, where he attended one religious gathering in Kuala Lumpur, and when they tested him, it was positive that time. So by timely notifications, our team in Malaysia had activated our rapid assessment team and rapid response team. That time we go down and investigate, and we identified that event were conducted and participate almost about 10,000 participants, and out of this 10,000, there are approximately about 1,500 500 of them of these participants are foreigners, come from 27 countries. So we immediately identify these 1,500 participants, and we immediately inform, because they already went back to their country. So we contacted these 27 IHR Focal Point as well as to the WHO to inform that this will be, additional for their risk assessment. There are possibility of them to contracted with COVID-19. So, and it was very timely because when we notified, it was before the Friday prayer will occur. So for that week. So can you imagine if they going back to their countries and they went to fight a Friday prayer, then it will be a massive transmissions all over the world. So this is one of the example how IHR Focal Point will assist and facilitate to contain the outbreak of COVID-19 all over the world. So this is the distributions of 27 countries that we had notified them. So if we can see, it's all over the world. And at the same time, we always maintaining communications between other member states, IHR Focal Point and WHO as well. So it was functioning 24 hours a day and 7 days a week. And all these informations, verifications need to be done urgently. And under IHR 2005, Article 44 on the assistance and collaborations, IHR Focal Point Malaysia actively involved in assist in contact tracing activity involving other countries. For examples, like if we had identified the travelers coming to Malaysia or Malaysian travelers coming to Malaysia from other countries and they've been positive for COVID-19, we will obtain more information on places they go, who are the identified close contact at the countries, and we immediately inform the countries so that they can conduct immediately contact tracings to contain the outbreak at the source of infections. And of course, we always maintaining information sharings and disseminations of information internationally and internally. And this is one of the requirements for IHR 2005. Of course, this COVID-19 pandemic is one of the unprecedented event, and we never thought before that we're going to have a long stretch of pandemic, whereby it's almost more than a year we've been fighting this pandemic. So of course, the preparedness and the response that we had done before will be exhausted. But what I can conclude at early part of pandemic, I think globally we had responded it very well in comparing on our previous pandemic 2009. But yet we have to identify what would be the weakness and what would we can do or can be done in the future. There are still gap of capacity and capability building at the countries, at the regional level, as well as the global level in the responding to the pandemic itself. So basically, the gap and the inequality of capacity building need to be addressed. That it's not only the country problems, but it's also the regional and global problems. So there are still lack of coordinations between countries, regions, and global. So in responding to pandemic, of course, we can see that there are a few incidents whereby if the information is transferred more transparent, the coordination is much more better, we can improve the situations better. So, and again, there's no standardizations of the role of IHR Focal Point between member states, and it need to be strengthened out. Transparency and information sharing need to be improved in order to combat pandemic COVID-19 globally. So basically, this is the quote that I got from The Art of War. So every battle is won or lost before it even fought. And again, if we think about it, responding to pandemic is only the icing on the top of the cakes, but the important part is the preparedness, and the preparedness is not occur only in pandemic, but it is occur way before pandemic. And during pandemic, we have to continuously improve our strategic and preparedness plan for the future. So with that, thank you.
Okay. Thank you to sorry, a bit raining here. Okay, thank you to Dr. Siti Aisyah. We would like to invite the second speaker today, Mr. Ferry. Mr. Ferry is the public health lecturer from Universitas Muhammadiyah, Kalimantan Timur, Indonesia. He specialized in health law, health administrations, health education, and psychology. His recent research are preventing fraud and deficit through optimizations of health insurance in Indonesia, the influence of physical distance to students' anxiety on COVID-19 in Indonesia, health communication model based on character educations to improve university student achievement in midwifery and other health-related research. With his strong knowledge and research, we are very honored to invite him to share the perspective on Indonesia towards IHR 2005 and pandemic. Now let's welcome Mr. Ferry to give the talk.
Okay, thank you, Dr. Lim. Thank you for this change. I'm grateful to be invited speaker at this event. CPD is about collaboration between UMKT and UPM, migrating also the audience from rector, dean, professor, student, and also related stakeholder in public health disciplines. It's very interesting presentation from Dr. Aisyah. They talk about more preventing COVID-19 based on IHR 2005. But in my presentation now about IHR and how to Indonesian prevent during COVID-19. I'm currently now as a lecturer in Public Health Department, University of Muhammadiyah Kalimantan Timur, and I'm studying in healthcare administration in Taiwan. The outline material will be arranged following. First is about global health security. The second one is about spectrum health security threats. Third one is about chronological development IHR and implementing IHR in Indonesia, IHR boundaries against COVID-19. But sorry, sometimes I will deliver in Bahasa for more clearly because I thought the majority participant is from Indonesia. Okay, I will share my PPT first. Okay, sorry. Is it already show or not? Okay.
Yes.
Okay, wait. Okay, this is my presentation. Before we discuss about international health regulation, we need to understand about IHR in general. Why IHR implemented in Indonesia? Okay, in Indonesia, because IHR regulates international activities, they have three activities regulated in IHR. The first one is about traveling. Traveling, they regulated about people, transportation, and goods, and also they regulate about the trade. It is about the cross border of one or several countries, and about shipment. It's about the goods, animal, and plants. Sorry. Sorry, this one. Every years there are significant increase in the number of flight. We see the table number of flight performance by global airlines industry from 2040 until 2018. The statistic give a number of flights globally by the airlines industry from 2004 until 2018. Passenger air traffic, the number would be increased. In 2017 is around 36 million were operated in worldwide. Okay, we can see how busy the flight routes are in Indonesia and Malaysia. And this one about the global health security. Before we discuss about international health regulation, why we are concerned about national and global threats. The first one is about emergence and reemergence of infectious disease and increased pace of spread. The second one is about globalization, public health, even in one location can be treated to the others. Third one is about serious and unusual disease. Events are increasing and inevitable. Threat of deliberated use of biological and chemical agents, laboratory and industrial accidents. And the last one is about impact of health, economy, and securities. We need to know about global health. For instance, laboratory, economic growth, and security will be impact on health. Okay. In previous slide, I mentioned about a health issue will be impact in economic growth. Now we can we can show the slide. The economic impact recent epidemic in 2014. In previous, Dr. Siti mentioned about SARS in China, Hong Kong, and Singapore, and the impact of economic it would be $50 billion. In previous pandemic, for instance SARS is estimate cost about 15 million. Yes, and this one about case study in Ebola virus was first discovered in Africa and spread widely to another country because lack of effective intervention. We can see in Africa from a table from the figure we can see how the disease spread in another country. Sorry. Okay, the another one's Ebola implication. The U.S. involvement only after America infected, and the policy, how the health system fight the pandemic for the sustainable development, and about national security. This says no borders regardless of intent. Disease outbreak test the domestic security and destabilize national affect all. About public diplomacy, we know after Ebola pandemic, mass panic and public misunderstanding. And another case about America trucks. We know on September 18, 2001, 5 U.S. senators and several media companies were sent letterless with the bacterium to anthrax. And 5 people died from the attack, and 17 others were infected with anthrax and survived. No country admitted to the attack, through Iran admitted to fire testing in 1998. Sorry. This is about American threats implication. Foreign affairs responses about US assume foreign resource. The policy about surveillance system, how the preparedness and how the responses, how about personal reliability, and how about culture and responsibility. About national security, government, people unprepared. And about system tested in about American struck, it for now for that times is not will be tested. About disease outbreak regardless of intent must be detected and controlled. About public diplomacy, it seems about a mass panic and public misunderstanding. Okay. Now, my question is, it seems between two cases about Ebola and anthrax. Before we discuss about that, we want to talk about a spectrum of health security threats. The first one is about chronic disease. As shown in the pictures, we have to know about the spectrum in the chronic disease, infectious disease, dual-use technology, bioterror, and biowar. The hypothesis is a good global health security policy will be reduce the impact of the left and the spectrum. The second one is about reduce the likelihood of the right and of the spectrum. The third one is provide some transparency regarding capabilities and intent. The fourth one is undermine the popular support for terrorism. Now we talk about the chronic disease. Chronic disease, they have NCDs or non-communicable disease. Majority from the picture we know a majority in 6 above age group death due to non-communicable disease. It's around 60% of the world's annual deaths are due to non-communicable disease, such as cardiovascular disease, diabetes, chronic respiratory disease, and cancer. As shown as in the figure that data estimate total death attributed to non-communicable disease will be increased in 2030. We see the in the 2003 until 2030 estimate data would be increased for non-communicable disease. And the another health threat is about death from drug-resistant infection, death from antimicrobial resistant infection and other causes in 2050 would be increased. For example, antimicrobial resistant infection, drug resistant due to the unwise use of antibiotics. And another health threat is about dual use. At the beginning of the spread of the corona, there was conspiracy theory that corona was a biological weapon from China, but however, it's not proven. The categorical of toxic industrial chemical and material includes substances that are commonly used in industrial, commercial, or medical process that have the potential to be used as weapon. For example, an ammonia, chlorine, pesticide, and hydrogen cyanide. Sorry. And for example, sequencing Spanish flu, gain of function research, scientific biology, DIA bio high containment labs. That's our challenge about that. How to regulation of science and how about ethical and how about national versus global policy. bioterrorism involving the intentional release or dissemination of biological agents. These agents are bacteria, virus, insects, fungi, or toxins, and may be in a natural occurring of human modified form in much the same way as biological warfare. This you can see the picture about the spectrum of health security threats. If moved the right, then it means getting more seriously. For example, about bioterrorism, American threats. Good global health security policy addresses the entire spectrum. Now we talk about GHI. The Global Health Security Agenda is a multilateral effort to accelerate progress toward global implementation of the international health regulation. They have three pillars of GHA. The first one is about prevent or mitigate the impact of naturally occurring outbreak and intention or accidental release of dangerous pathogens. The second one is about rapid detect and transparently report outbreak when they occur. The third one is employ an interconnected global network that can respond rapidly and effectively. Now, what are the International Health Regulation 2005? IHR 2005 is a internationally agreed instrument for global public health security, represented the Joint Committee for Shared Responsibility and Collective Defense Against Disease Spread, and about legally binding from WHO member states since June 2007. Now we talk about what's the difference between IHR 1969 and IHR 2005. In IHR 2005 is an amendment from IHR 1965. IHR 1969. No disease transmissions, both cholera, pest, and yellow fever from one country to another due to international travel. In 2015, 2005, prevent, protect against, combat the spread of disease. Yes. Okay. This is between countries without uncertainly travel threat restriction, and for example, radionuclide and chemical agent. IHR 2005 revision is about a public health emergency of international concerns. Is an extraordinary event which is determined to constitute a public health risk to other states through the international spread of disease and to potentially require coordinated international responses. This is about revision in 2000 IHL 2005. WHO will be notified Public Health Emergency International Committee, International IHR Focal Point between the officially, and the definition about core capacities is about how various sector in every sector level. For example, port health services and the healthcare delivery healthcare system to detect, report, and manage risk against a health problem, and about recommendation action by WHO and how to decision about emergency committee IHR review committee. This is about criteria PIIC, a public health emergency of international concerns, about condition, geographic, time, when outbreak occurs, about scale outbreak, proximity to an international border or airport, and speed of and mode of transmission, amongst other factors. This is about timeline. The IHR 2005 comes into force on 5 June in 2007. States parties shall meet the core capacity requires. This is about paradigm shift 2005. Before in IHR 1969, is about a control of borders and also containment at sources from disease list and outreach and from present measures to adapted and real-time responses. The purpose of revisions IHR is about prevent, about the public health risk, and which avoid unnecessary interference with international traffic threat. This is about highlight of IHR. It's about a much broader scope, public health emergencies, international concerns, more operational national and WHO, IHR Focal Point, and competent authorities, recommended measures from WHO, consultation, notification, verification, and assessment, and also new obligation, national core capacities requirements. This is also mentioned before from Dr. Siti about transparency, partnership, collective responsibility, standardization, quality, and about the building on access program. The surveillance and response capacity required by IHR, it about in Indonesia also divided with 3 levels. The first one is about local level, is about detecting of event, reporting, and control measures. And second one is about intermediate level, is about confirmation, assessment, and reporting. And about the large is about national level, is about assessment, notification from WHO, and public health responses is about control measures, support, on-site assistant, operational link, license, public health emergency response plan on 24 hours basis. Okay. Now IHR have core capacities. They have 8. They have a national legislation, coordination, about national focal point and communication, surveillance, response, preparedness, risk communication, human resource, laboratory, point of entry, capacities for IHR relevant hazards. For example, infectious disease, zoonosis, food safety, chemical, radio, nuclear. In Indonesia also, they have 3 levels about national, intermediate, and peripheral community. I already mentioned before. It's about human resource, laboratory, risk communication, preparedness, response, surveillance, coordination, and legislation. Now we talk about according to recent WHO study review in IHR implementations in the world, only 50% or about half from the 182 countries analysis have strong operational readiness. That means they have a lack of operational readiness capacities in place. Indonesia also they have some limitation about that because Indonesia is a very large country and it's very difficult to build coordination due to limited resources. Now I will discuss a perspective about the legal instrument actors, how to implement national health regulation regarding international health regulation. This is about implementation international health regulation to national health regulation. Who is actor to implement the international health regulation to national health regulation? Implementation of public health system and surveillance and about national health regulation. The actor of international health regulation to national health regulation, we have 3. We have a government, community, and private sector. Private sector also non-national, non-governments, NGO, good governance concepts, and private sector, community, and governance. Health system, according to WHO, is about a health system consists of all organizations, people, and action whose primary intent to promote, restore, or maintain health. because Indonesia we have a different different healthcare system between Malaysia. We have a decentralization policy and centralization policy. If they have a pandemic, there would be centralization policy. But for preparedness, we have a decentralization policy. For example, the government's health service institution would be maintain health status. And how is the performance of the managed system? It's also private institution and non-government organization. This is about system healthcare system in Indonesia. It's also following the WHO. The first one is the point is about stewardship or leaderships. And also in Indonesia, we divided between two. The first one is a macro. Macro is about stewardship, creating resources, delivering services, and micro health system is about responsiveness, how to maintaining health status, and about financial contribution. This is about response surveillance system concept from WHO. We have a surveillance and response. Also, we have a structure surveillance about legislation, law, how to strategic surveillance, data flow, and networking partnership. And also, we have a function about surveillance about how to registration, confirmation, reporting, the early detection cases, analysis, interpretation, and also feedback and response planning responses. This is about workflow surveillance. The first one is about collecting data, and also we have analysis interpretation about challenging risk group, and about new analytical tools about how to new dissemination technique, and how to dissemination information to another stakeholders, and how to utilization results. In Indonesia, we have a regulation about about the implementation international health regulation is in Kepmenkes, Peraturan Menteri Kesehatan. It's mean organization in the center and the district also. There would be implementation about the surat edaran or Kepmenkes like that. The target is about the problem health issues, and then they will decision about priority national, bilateral, regional, and global. And the lingkupnya adalah about non-communicable disease and communicable disease, and also about health promotion and health sanitation. We have epidemiological surveillance network and consists of collaborative network between surveillance units and health service providers, laboratories, and other supporting units. Collaborative network between epidemiological surveillance unit and research and study centers. Collaborative network of epidemiological surveillance and cooperative network of surveillance unit with the various relevant national, bilateral, regional, and international sectors. This is about networking surveillance epidemiological in Indonesia. We can see they have a central unit, and they will deliver to district and also to province, and they will cooperate with private sector in this one. They will and also they will collaboration with research data and research center, and the external collaborative. It means it's university, center agency of statistic, meteorological and climatology, geophysics council, non-government organization, uh, the health organization provisions, and drug council, and also another department in bilateral, regional, and global. The surveillance will be implemented until healthcare's primary healthcare also. This is about stakeholder in surveillance. We have from health research centers, non-government organizations, community, primary healthcare, private hospital, governments, and also district Ministry of Health. This is about core capacities, epidemiology surveillance. PIC, public health emergency, encourage awareness of the possibility of PIC and follow-up response. And this is, we know about early detection. Early detection will be reported and have an early response in the city and district, and also in primary healthcare. But about early detection and advanced response, it would be Dirjen PPL and Dinkes Provinsi. This is about workflow national health quarantine network subject from IHR. Also, Indonesian follow from IHR 2005. We have a CDC, Central for Disease Control. We have a for entrance international port health. It would be delivered from KKP or Kantor Kesehatan Pelabuhan, or port health department. This is about stratification surveillance. The first one is about early detection and reporting. This is about analysis and investigations from health port department or KKP or Kantor Kesehatan Pelabuhan. This is a center or national focal point. It's about Departemen Kesehatan. And also in the international regulation, we need to analysis and feedback from WHO for supporting decision and supporting policy. This is about in Indonesia, also part of member WHO. They need to designate a focal point, and they also they need to focal point in the district and in the city, and also they have a verification and how to prevent the risk and also they need to build the core capacities in the surveillance. In WHO, they have defined contact focal points in the health quarantine until sorry. And also they collecting data, and also they need to help a technical problem or technical issue. And the last one is about recommendation how to implement that about primary about the PAIHC. This one about legal standing surveillance in Indonesia. The first one is about X law and also government's regulations. We have a peraturan presiden. It's mean presidential regulations, And we have a peraturan menteri, it's mean a ministerial regulation, and we have a peraturan daerah or regional regulation for technical implementation operationally in regions. This is about implementation in Indonesia. Now we have until now I have data about core capacities on the surveillance and POA are less optimum because we know Indonesia is very large country and very hard to coordination because we have a limitation about resources. This is about COVID-19 and rule of law in Indonesia. The first one is about Presidential Decree number 7 about acceleration of the country coronavirus diseases in 2019, handling led by Task Force Steering Council. Is it about mandates governors as member of the Task Force Steering Council by forming task force at the regional level to monitor and evaluate the implementation of COVID-19 countermeasures in the respective regions. The second one is about Indonesian government has issued 3 regulations in the last 2 weeks as a part of possible implementation of large-scale lockdown in the country, but on regional basis. So the lockdown is mean not in the other country in our in a country, but only in regional basis. Or in bahasa it's mean pembatasan sosial berskala besar. Is aimed at reinforcing the effect of social distancing policy already applied since 15 March 2020. And also law number 6 2018 about health quarantine. The application of emergency in the law refers to the term of kedaruratan kesehatan masyarakat or public health emergency. Public health emergencies mean a community phenomenon characterized by the spread of infection disease and or incidents caused by nuclear radiation, biological contamination, chemical contamination, bioterrorism, and food that pose a health hazard and potentially spread across region or country. In the law number 6, they have a type of condition. Number 1 is about authority. Authority in public health emergency situation is a presidential, governor, district, and city mayor. The implementer is central government, Ministry of Health in the center, and governor and the district city mayor in the district or in the city. Declarating mechanism is about subjectivity of presidents, is a Ministry of Health. This is a Ministry Health organizes functions. I know I cannot describe all, but I just describe another point, just a little bit point. For example, the first one is about formulation, determination, and implementation of the public health policy, prevention and disease control, healthcare, pharmaceutical, and medical devices. And also in the Ministry Health authorities, they need to countermeasures and disaster that are nationwide in health. In the Ministry Health authorities, they need to determination and screening guidelines develop and application of the health technology and ethical standard for health research, epidemiological surveillance and control epidemiology and control epidemic, infection, disease, and extraordinary events. And another one is about provision of certain essential drug and medicines for basic health services is essential.
Halo, Halo, Assalamualaikum. Salam, Dek. Iya, Pak. Iya, bentar kita tunggu si ini lagi satu baran.
Sorry, Mr. Ferry, please unmute the mic. Thank you.
Okay, I'm sorry. This is about IHR boundaries against COVID-19. The COVID-19 outbreak has laid bare the fragmentation problem of international law. Sorry. This is about respond government to combating COVID-19. The first one is about quarantine of foreign national arriving at airports. IHR 2005 permits quarantine and non-intrusive medical examination in global health crisis situation. When a quarantine escalates to detention, however, a different set of legal rules comes into the equation. Sorry. We know from the Vienna Convention on Consular Relation requires the detaining state to inform a consul of national state of a foreigner and ensure communication between them. And the second one is about export restriction of medical item or daily hygiene essentials such as face masks and have implication for trade rules. After pandemic measures can create exception to the general agreement on traffics and trade rules. And also exercising regulatory authority over cruise ships. This is a lesson learned from Japan's. Exercising regulatory authority over cruise ships docked at port have also sparked controversy who should be in charge or responsible. For example, a port state, a flag state, or the state of a passenger nationality. While international law has long addressed this type of issue from the point of how to organize competing countries overlapping jurisdiction, the COVID-19 affected cruise ship situation is rather distinct, as no state apparently want to exercise jurisdiction to avoid triggering state responsibility. This is the last my presentation about conclusion. The IHR is far from perfect. The IHR only governs country, not corporation and other non-governmental actors. Thus, some countries are finding themselves with the factor travel restriction when airlines stop flying to places affected by COVID-19. Additionally, the IHR doesn't have robust accountability mechanism for compliance, enforcement, oversight, and transparency. And also, however, the IHR is a legally binding system for protecting people worldwide from the globally spread of disease, with more than 25 billion, 2.5 billion people traveling between about 4,000 airports every year. Future outbreaks are inevitable. Response that are encouraged is in fear, misinformation, racism, and xenophobia will not save us from outbreak like a COVID-19. Countries can be started by rolling back illegal travel restrictions that have already been implemented and by supporting WHO and each other in the implementing the IHR. Despite that, the fact that the WHO is an important instrument based precisely on coronavirus families, the COVID-19 show has research limit and deeper reflection is needed for the future.
Hai Tasya, kamu apa kabar hari ini? Masa Febri ngomong di seminar Zoom? Demi apa?
Okay, that's all my presentation. I hope we can share good insight for this field. We will future wait for Q&A section. Thank you.
Okay, thank you to Mr. Ferry for this wonderful talk. And I would like to invite Dr. Siti Aisha and Mr. Ferry to stand by for the Q&A sections. Now is begin the Q&A section. May I know anyone has question would like to ask Dr. Siti Aisha or Mr. Ferry? question that would like to ask? Okay, let me start for the first question. I would like to ask Dr. Siti Aisyah. Dr. Siti Aisyah? Yeah. Yeah. So based on what you say that there is lack of standardizations of the role of IHR focal points between member states, right? So what we can do in order to standardize it in order that as we know that when we have the standardized role of the IHR focal points, it will help for this pandemic, right? So what is the suggestion from you?
Okay, so when we are talking about this, thank you, Dr. Lim, for the question. So, if we are talking about this, what we call it, standardizations of these IHR focal points. So every country depends on the commitments of them. And one of the compulsory requirement is for them to do verifications and notify WHO for any potential public health emergency of international concerns. But if you are looking at other rules of IHR focal point, as I mentioned that, the communications between the member states using IHR focal point platform, it was not really standardized. So some countries do actively, informing other countries on during pandemic on contact tracings, but some countries did not, and it will be it was not fully falls under IHR recommendation. So basically, if WHO can come out with a standard guideline and requirement for IHR focal point, instead of verification informations and information sharings, if they can justifies on the reason and the what we call it, the success story of this timely communications of IHR focal point, I think that will be great. And there are a lot more examples, such as what I mentioned just now on how we contains our outbreak in Seri Petaling, how managed to contain our first wave by having this good communication between member states. So I believe that if we maintaining these good communications between member states, it will be further strengthened and the response could be much more faster. And without, I think we believe it, we can shorten or we can flatten our pandemic, rather than we have now. So that is something that they are lacking, and I believe that it was something that being suggested and being before to WHO, and I think based on this pandemic and based on this successful story, I think we have to highlight that we require a standardization of information sharing and transparency between member states.
Okay, thank you to Dr. Siti Aisyah. May I know any question from the ground, from the floor? Okay, let me ask one question to Mr. Faris.
Yes.
Okay, and actually, just now Dr. Siti Aisyah got mentioned some of the challenges of Malaysia facing, right, like of a lack of the communications and about the gaps of the capacity and capabilities, no standardizations on the role. May I know any challenge that Indonesia face for during this pandemic, and what is the solutions that already developed or modified in order to fight for the challenges?
Okay. In Indonesia, we are already mentioned before, but because Indonesia is very large country, and it's very hard to coordination between each part, because Indonesia is a island country, right? Or maybe I will share in bahasa, sorry. Because Indonesia adalah negara kepulauan, sangat susah untuk berkoordinasi. Kita bisa lihat di WHO Di situ kita bisa lihat bahwa core Indonesia yang paling rendah itu adalah bagaimana dibandingkan dengan negara-negara lain, itu adalah bagaimana berkoordinasi antar sektor, bahkan di sektor kesehatan pun cukup susah karena memang Indonesia wilayah luas dan memang terdapat beberapa keterbatasan sumber daya. Contoh hal misalnya negara yang berbatasan dengan Papua Nugini itu adalah Provinsi Papua. Nah, di situ kan ada beberapa lintas batas yang memang secara alam itu bersatu, namun untuk penjagaan cukup sulit, cukup susah. Nah, namun memang keterbatasan itu bisa kita atasi dengan cara adalah bagaimana deteksi dini dan pelaporan dini awal dari setiap entrance focal point ya, pintu masuk focal point. Jadi di setiap perbatasan memang punya kantor kesehatan pelabuhan, dan juga untuk penerbangan pelabuhan itu sudah cukup baik pengawasannya. Namun untuk lintas batas itu memang agak susah. Terutama misalnya di Kalimantan, di UMKT, kita berbatasan langsung dengan Malaysia. Beberapa daerah itu juga warga tradisional itu untuk berobat mereka langsung ke Malaysia lebih dekat dibanding Indonesia. We know about disease, they don't have a border. Yes, kan kita tahu bahwa penyakit itu tidak punya batas wilayah. Jadi ini dari awal saat saya mengambil tesis S2 saya mengenai IHR di perbatasan, ya susah untuk mengantisipasi untuk wilayah perbatasan, terutama di daerah-daerah yang masih memiliki keterbatasan sumber daya. Seperti itu.
Okay, thank you to Mr. Ferry. Okay. Before I continue, for the Q&A sections, if those who are not able to go to the Google link to fill in your attendance, you can scan the QR code here. Okay, there is one question from the floor, from the chat box. Wait, or any question that you want to ask, you can unmute your mic.
I have one question, Dr. Lee.
Please. Yes, please.
This is Kalsom from PM. I would like to thank Mr. Ferry and Dr. Aisha for a wonderful presentation. As mentioned very clearly, is that the IHR does not have, although it's legally binding, it doesn't have an actual system to ensure accountability in the sense that the member states comply to the regulations, correct? And we also we have observed during the pandemic that the fragmentation is very obvious in terms of coordination, response, and things like that. So going forward, do you think that what is the way to go in terms of ensuring accountability in terms of compliance to IHR? Thank you.
Thank you. So, Dr. Siti Aisha or Mr. Ferry, who would like to answer the question?
Okay, I will deliver in bahasa. Sorry. So, in Indonesia, cara yang paling mudah adalah berkoordinasi berdasarkan 3 pilihan tadi. Yang pertama adalah bagaimana kita memperkuat di regulasi untuk di sektor pusat, dan bagaimana koordinasi dari mengimplementasikan IHR yang sudah diratifikasi dalam National Health Regulation itu dapat diimplementasikan di setiap focal point. Yang berikutnya adalah bagaimana penguatan pelaporan dan deteksi dini di setiap primary healthcare. Kalau di Indonesia jika di Indonesia namanya itu adalah puskesmas, bagaimana sistem pelaporannya dan bagaimana pula coordination between lintas sektor, for example KKP or Port Health Department atau kantor kesehatan pelabuhan atau kantor kesyah bandaran. itu mengirimkan pelaporan kepada pusat. Cuman permasalahannya di sini adalah ya resource tadi, bagaimana sistem pelaporan itu dapat diselesaikan dalam waktu 24 jam. Itu sangat susah, terutama untuk di daerah yang langsung berbatasan. Kita tidak bisa memungkiri bahwa Indonesia, wilayah yang berdekatan dengan negara tetangga itu memiliki keterbatasan sumber daya. Contoh hal misalnya di Papua dan di Indonesia di bagian utara, untuk masalah connection jaringan itu juga menjadi kendala. Terutama juga keterbatasan sumber daya manusia di daerah itu juga menjadi hambatan mungkin, tetapi itu tidak menjadi menjadi hambatan utama karena memang Indonesia sedang bergerak menuju ke sana. Terutama untuk COVID, kita sudah melakukan herd immunity melalui program vaksin di beberapa sektor, yaitu untuk saat ini di fase pertama ini adalah petugas kesehatan dan tenaga pelayanan publik. Namun untuk petugas masyarakat umum mungkin di fase berikutnya. Ini berbeda hal. We have a lesson learned from Taiwan because I live in Taiwan now. For now, in Taiwan we have a different way to against COVID. Mereka di Taiwan, mereka cukup percaya diri untuk melaksanakan karantina secara mandiri dengan biaya pribadi. Jadi it's your decision if you going to abroad, itu adalah pilihan kamu untuk keluar dari negeri, keluar dari Taiwan. Jika kamu kembali, kamu harus dikarantina secara mandiri dan kamu harus tes PCR. Dan karantinanya pun itu harus di quarantine center. Jadi mereka tidak perlu melakukan herd immunity dengan vaksin untuk sementara saat ini, sembari menunggu efikasi vaksin di beberapa negara. Mungkin kalau di Taiwan seperti itu. Cuman kalau di Indonesia sangat susah untuk sistem seperti itu karena memang sistem pelaporan yang sangat susah seperti itu. Itu sih dari Indonesia.
Okay.
So Dr. Lim, maybe I can also comment on what Dr. Kalsom had been asked. So I remember that in my previous presentations, I did mention on, even though, that was one of the challenge, and I just read through on the technical expert report on this response of pandemics by WHO. So they just published it, and it's still interim guidelines. So the expert also mentioned and highlighted what Dr. Kalsom also had found. Yeah, they are still fragmented, and this IHR, yes, it is internationally legally regulations, but it was not a mandatory compulsory for the countries to implement to build up capacity. But if you can refer back on the monitoring and evaluations of IHR Focal Point, where the country required to annually report during WHA, and we also had to submit a written report on the performance of IHR capacity. That was one of the initiative by WHO, since that basically even though the spirit of IHR is basically on the legally document, but yet the country is still a center. So basically the country decisions will be differ from other countries, and from one country to another countries, and we have to find out where are the meeting point between these. And of course, like Dr. Freddy mentioned just now, why global health security is very important, so that we know by building up capacity and reporting regularly, so the capacity building is not only confined to the capacity of the country, but also at the regional level as well as the global level, so that we know if we only, or our country only, build up our capacity at the country, we cannot contain the pandemic itself, because it's involved globally. So that's why some developed country, they start investing in countries around them, so that they will be providing a buffer for them. But I think what Dr. Kalsom mentioned, yes, WHO indeed required to take the step up measures after this pandemic, lesson learned from this, so that it's not a kind of enforcement, but we have to find out how, why, and where is our meeting point, so that every country be able to keep up their minimum capacity and capability so that there will be no inequalities. So if we see our countries, maybe we have to thought about other countries that, pandemic could be a problem, but they're also facing other social problems. They are facing, war, natural disaster, whereby the capacity building will be not enough for them as well. So we have to address, this is some of the issue which involve or occur globally, and it's not only affecting that particular country, but it's affecting the whole global response towards it. And yes, Dr. Kasum, yeah, it is one of the biggest fragmented that I think we have to highlight the challenges of implementation of IHR.
Okay. Thank you to Dr. Siti Aisha and Mr. Ferry for this. There is one question from the floor. Before that, I should say that thank you for this.
Hello.
Yeah, Lisa.
Hello. Yes.
Yeah, Lisa, would you like to
Oh, sorry. Yes.
ask the question by own?
Yeah. Yes. Yes.
Okay.
Yes.
Yeah.
Thank you for the opportunity. I am Lisa from the Public Health Department in Muhammadiyah University of Kalimantan. I thank you for the wonderful presentation regarding international health regulation from the Dr. Siti Aisyah and Dr. Ferry. I have one question for Dr. Siti Aisyah and also one question for Dr. Ferry. And for the first Dr. Siti Aisyah, regarding the current situation, what's your opinion? For the conclusion, for the globally, is it possible the pandemic end by this year? And one question for Dr. Ferry regarding at core capacity. As we know that Indonesia have heterogeneity community characteristics. So which one the priority to emphasis to applying in Indonesia? Or it should to conduct it simultaneously? Okay, thank you.
Okay, thank you, Dr. Lisa, for the question. So I'll answer the first question first. With regards on, is the pandemic ended by end of this year? Looking back, yes, one of the positive factor now, most of the country already started on the national vaccination program, and if we can see that by I think end of the February last February, there are already about 50 countries already started implementations of national COVID-19 immunization program. But yet, if you see the trend now, we started to see various variants of COVID-19 virus, which one thing that, I cautiously interpret because, one, we have to look at the effectiveness of this vaccination program, as well as what is the effectiveness of towards this new variants. So, and we already had, we just started by April. So I'm a bit cautious to say that we're going to end the pandemic by end of the year. I think it takes much more longer time to end this.
Thank you to Dr. Siti Aisha. How about Mr. Ferry for Lisa question?
Okay, I will refer in Bahasa. Because I already mentioned before about IHR core capacities. They have 8 core capacities. And regarding the question from Lisa, is which part poin mana yang paling baik untuk Indonesia karena memiliki berbagai macam budaya, culture, dan lain-lain. Saya rasa dari 8 ini dan sudah dievaluasi melalui WHO, poin yang paling cukup krusial untuk Indonesia saat ini adalah bagaimana coordination between national focal points and how to communicate between sectors. Jadi lintas sektor dan bagaimana responsesnya. Mungkin Indonesia sudah berkali-kali melakukan preparedness pada saat itu SARS, Indonesia bisa meng-counter penyebaran virus SARS. Namun untuk COVID-19 pada saat ini Indonesia sudah berkali-kali mencoba mengcounter, namun pada akhirnya mungkin data menunjukkan bahwa Indonesia terus meningkat datanya secara signifikan. Jadi menurut saya yang paling baik saat ini adalah bagaimana koordinasi lintas sektor dan bagaimana mengkomunikasikannya untuk memberantas menanggulangi masalah COVID melalui core capacities tersebut, yaitu pada poin coordination and national focal points. Untuk national legislation, policy and financing, saya rasa Indonesia sudah cukup baik, di mana beberapa aturan, beberapa hukum itu sudah dibuat, namun masalah pelaksanaan implementingnya itu memang cukup sulit karena setiap kali melakukan terdapat perubahan-perubahan ini mengikuti perubahan kebijakan dari dunia juga. Jadi ya mungkin keterbatasan itu yang membuat Indonesia mungkin angka kasus IHR-nya, angka kasus COVID-nya itu cukup tinggi. Mungkin itu.
Okay, thank you, Mr. Ferry. Any question from the floor? Any question from the floor? I have one question to Mr. Ferry. Since you are in Taiwan right now, right? Some of what the news keeps saying that sometimes they were saying that Taiwan is one of the best of the country that
yes.
COVID-19. So what do you think that, I'm not sure because I'm not from Taiwan, I'm not been there for long.
Yeah.
So when you are there, could you see that what is the strategy that they use might be able to apply into Indonesia or Malaysia?
Yeah, sorry, I will deliver in bahasa.
Yeah, no problems.
For more, I think if I deliver in English, it's very hard to think.
It's okay. It's no problems.
Regarding from my experience, jadi Taiwan cukup percaya diri. Pertama adalah politik mereka sebagai negara untuk diakui secara global. Itu salah satu kampanye mereka saat ini. Bagaimana warga masyarakatnya bersatu padu untuk mengkampanyekan bahwa Taiwan adalah part of WFO. Walaupun saat ini Taiwan tidak diakui, namun secara prestasi WHO mengakui bahwa Taiwan adalah salah satu negara yang hingga saat ini bisa memprevent COVID. Hingga dengan kebijakan itu pula mereka tidak menganjurkan penggunaan vaksinasi hingga sampai saat ini, menunggu beberapa negara melaporkan efikasi dan long term jangka panjang, efek negatif jangka panjang yang terjadi pasca vaksinasi. Jadi yang saya rasakan di sini adalah bagaimana masyarakat itu patuh terhadap aturan, itu satu. Yang kedua adalah sistem informasi yang memang menjadi kendala di negara kita, negara saya di Indonesia, mungkin juga di Malaysia, beberapa negara rural, daerah rural itu keterbatasan sistem informasi karena pada saat karantina kita dipantau secara GPS. Jadi saat kita keluar dari ruangan itu akan terpantau langsung dan terreport secara automatically ke kantor kepolisian dan dinas kesehatan. Dan dia juga harus melakukan self-reporting by SMS gateway, setiap hari melaporkan apakah ada simptom atau terjadi masalah. Selanjutnya mereka juga wajib untuk tes PCR pasca karantina selama 14 hari. Dan itu sifatnya mandatori dan dibiayai dari secara pribadi. Dan itu yang membuat masyarakat Taiwan terlindungi dari penyebaran COVID. Dan hingga sampai saat ini penyebaran COVID hanya dari import case, tidak dari lokal case seperti itu. Gitu.
Okay. Thank you for your sharing.
Yeah.
Okay. Any last question from the floor? Before I end this vlog, okay, so at the end, I would like to thank you to Department of Community Health, Faculty of Medicine and Health Sciences from UPM, and Faculty of Public Health, Universitas Muhammadiyah Kalimantan Timur, Indonesia, to organize this wonderful continuous professional development today. And I would like to thanks to our two great speakers, Dr. Siti Aisha and Mr. Ferry, and all the participants. And hope to see you all on the next continuous professional development soon. Okay, thank you to everyone. Stay safe and stay healthy all the time. Thank you very much.
Thank you.
Thank you, thank you. Please remember to sign the attendance form via Google form. If you're not able to access the Google form, you can email to khairiab@upn.edu.my. Okay, with the details with name, emails, organizations, and staff metrics, staff number. Okay, thank you very much to everyone.